Hi guys, in this video we shall discuss about the diagnosis of COVID-19 infection. So whenever a patient presents to either the OPD or the emergency, examination is started with 1. Vitals, 2. Physical examination, 3. Lab specimen and diagnosis, and 4. Imaging. So we shall cover the diagnosis in that order. One important thing to note is that all these findings may not be present in all the patients and they differ according to the severity of the disease. So first, coming to the vitals, when we look at the respiratory rate, there is usually increase in the respiratory rate, which indicates the beginning of respiratory distress. The patient may also have a fever. The heart rate is elevated. Now this elevation of the heart rate may either be due to fever or due to shock. Now the BP can either be low, that is hypotension, which is usually seen in the stage of shock, or the patient may be normotensive. Now coming to the physical examination of the patient, on inspection, there is increased work of breathing, that is the accessory muscles of respiration are used. There is decreased movement on the side that is affected. Now on palpation, we'll find that the movement on the affected side would be reduced. Trachea would be central, that is normal in its location, and vocal fremitus will be increased. This finding is usually seen when there is a consolidation in the lung. On percussion, we may find dullness, which can be either due to consolidation or due to pleural effusion. On auscultation, bronchial breath sounds will be heard and there will be increased vocal resonance. This is nothing but the auscultatory finding of increased vocal fremitus. We may find bronchophony, agophony, pleural rub, rhonchi, and crepitations. Now fine crepitations are usually heard in the stage of congestion and coarse crepitations are usually heard in the stage of resolution. Now coming to lab diagnosis, the specimen which are taken include the upper respiratory tract specimens, which can be a nasal swab, oropharyngeal swab, nasopharyngeal swab, or a throat swab. Specimen from the lower respiratory tract include bronchoalveolar lavage, respiratory secretion, that is sputum can also be taken, and finally blood is taken for routine investigations. Now while collecting the swabs, it is advised to not use calcium alginate swabs or swabs with wooden shaft, as that can inactivate the virus and inhibit the PCR. Once the specimen is collected, it is immediately transferred into a sterile transport tube with 2 to 3 ml of viral transport medium. You can also use Amy's transport medium or sterile saline solution, unless the test is designed to analyze the specimen directly. Now the specimen can be stored at 2 to 8 degrees Celsius up till 72 hours. Beyond 72 hours, it should be stored at either minus 70 degrees Celsius or below. On analysis of the blood samples, the findings we may get are lymphopenia, neutrophilia, that is increase in neutrophils, increased AST, increased ALT. This signifies liver damage, increased blood urea nitrogen, increased serum creatinine, which signifies kidney damage, increased CKMB, increased troponin, which signifies damage to the heart musculature, and increased C-reactive protein, increased ferritin, increased lactate dehydrogenase, and increase in D-dimer. These are all the acute phase reactants, so it signifies ongoing inflammation. Procalcitonin may be increased if there is superimposed bacterial infection. In isolated viral infection, procalcitonin is not increased. Other tests on blood include antigen detection using immunochromatography, antibody testing. Now this detects the immune response to the virus in case of suspected exposure. So we test for IgM, which is usually raised 5 to 7 days after the infection, IgG, which is raised 10 to 15 days after the infection, and IgA is tested in mucosal secretions, usually seen 6 to 8 days after infection. Now, the serology alone cannot be used for the diagnosis of COVID-19 infection. It is only used to support the clinical assessment of persons who present late in the illness when used in conjunction with viral detection tests. On the other specimen, that is the upper respiratory tract, lower respiratory tract and sputum, we usually do RT-PCR to detect the genetic material. Now let us understand the basics behind RT-PCR. Reverse transcriptase polymerase chain reaction amplifies the genetic material of the said virus so that they can be detected by other techniques. It was invented by Dr. K. Mullis in 1989. So what the PCR technique does is, it synthesizes the complementary sequence of bases to any single strand of DNA, provided that it is double-stranded. This results in amplification of that specific region of the DNA. But since COVID-19 is an RNA virus, it only has a single strand and therefore complementary strand needs to be synthesized in order to make it double-stranded using the enzyme reverse transcriptase. And hence this process is known as RT-PCR. So now, once we have the double-stranded genetic material, we amplify it using the PCR technique. Let's see what we'll need. Number 1, specimen with the virus and its genetic material. Number 2, nucleotides. Now these are the bases which are required to synthesize complementary strands. That is, they will lead to elongation. Number 3, thermophilus polymerase. This is the enzyme which uses the nucleotides and synthesizes the complementary strand of the segment of DNA that we want to amplify. It has both polymerase activity as well as reverse transcriptase activity, and it functions at the temperature that is required for the process of PCR. However, it cannot start this amplification process on its own and requires a push which is provided by the primers, which are complementary to the initial few bases of the gene we want to amplify. So another thing that we'll need are primers. Primers are 18 to 25 nucleotides in length and are complementary to the gene sequence we want to amplify. They give specificity to this procedure by flanking the segment of DNA we want to amplify. So if we have a strand of DNA from 5' to 3' with the following sequence, the primer will go and attach to the 3' direction with the complementary set of bases, and this will be acted upon by TTH polymerase and elongated. Now, if the primers were not complementary to this sequence, it wouldn't have bound to this area and therefore this region would not have been amplified. Now, let us look at the procedure of PCR. The first step is denaturation. In this, the specimen is heated up to 90 to 96 degrees Celsius for 3 minutes. What this heat does is it overcomes the intermolecular forces of attraction between the complementary bases and separates the strand of DNA. Now the next step is annealing. Seeing the separated strand of DNA, the primers now get a chance to attach to the 3' end of the flanking sequence. This takes place at 50 to 75 degrees Celsius. Now, seeing the primers with the DNA, the TTH polymerase comes in and adds bases. This process is known as extension, which takes place at 68 to 75 degrees Celsius. This entire cycle takes about 5 to 10 minutes. When this cycle takes place once, it causes the formation of 2 strands of DNA from one parent DNA. So if this process is repeated n number of times, the total number of strands would be 2 raised to the power n. The CDC has issued 3 primers for detecting the N gene. One which is common for all beta coronaviruses and 2 specific for SARS-CoV-2, that is the coronavirus. A patient needs to be positive for all 3 to be labeled COVID positive. However, if only 2 are positive, then gene for RNA-dependent RNA polymerase is tested. So the summary of the lab diagnosis includes the blood findings and the specimen with the RT-PCR findings. This can be supported by antibody detection in the blood. Finally, coming to imaging. On chest X-ray, initially there may be small patchy shadows. Later on, when the disease becomes severe, the patient may even show infiltrating shadows, consolidation, or even pleural effusion. Now, these are mostly seen in the peripheral and the lower zones of the lung. On CT scan, we find bilateral, peripheral, ground glass opacities with basal predominance, likely due to pulmonary edema. Now, when ground glassing is present with reticular abnormalities, we call it crazy pavement pattern. And if ground glassing is surrounded by consolidation, this appearance is known as reverse halo. Now, thank you all for watching. That was all for this video. If you liked the video, please like, comment and share and subscribe for more such videos.